How would you feel in the morning? And then how would you feel about moving from that spot to find another spot to do the exact same thing for the next night? At what point would you begin to feel like this life was just shit? So examples of rough sleeping. This is Stockton. This is a little tent campus being formed about 12 miles from where I live. This was on the pier in Ocean Beach. I don't know how well you see it. If you have like your little app access, here's a gent sitting on a park bench. He's got a little cart. He's got all the stuff in there, sleeping bag, all that stuff. So my guess is when it gets dark, he's either going to find a spot nearby or he's got maybe a spot set aside somewhere else. I want you to just take a moment to read that because I can't do it justice. You heard some folks with Joe and Keith earlier, and this is from someone who's got pain issues, life on the streets. So here I'll say, at what point do we decide that maybe a biomedical model is really not the model that is going to do much to help this particular person find some different direction for their life? Oh, my title. You get about halfway through, and here we are. I've seen a lot of really good academic descriptions about what living with uncertainty means. And Ben has said, and a few others, oh, I don't have a red card, Eric, but this is going to be my red card. Okay? This is purely my opinion. What I take from living with uncertainty is I can go home, and I am fairly certain when I go home, my family's going to be there. My dog's going to be there. My bed's going to be there. And I'm fairly certain that when I go to bed at night and whatever sleep I get and wake up in the morning, they're going to be there as well. I'm going to go to work and I'm going to have a job and I'll go through all that stuff and I'll repeat that cycle over and over again. There's a little bit of predictive processing here maybe, right? So when that's no longer possible, what does that do for our sense of safety and security? What kind of behaviors are we going to do that may not be, from my perspective, all that helpful in trying to figure out how do you have less pain? Or how do you figure out how to do something functional when your whole function is just picking up your stuff and finding somewhere else to stay for the day and the night? This lady here, I know you can't, it's a tent, but the lady that lives in this tent, this is across the street from our downtown clinic. And so we are kind of in the thick of it. So I heard this psychologist, Wendy Wood, who's down actually, I guess up, at USC, and started talking about habits. And yesterday morning, I think it was, Sandy, we had this conversation about habits. And there's a lot of things that we do automatically, and we don't realize that we're doing them. Her assessment from some of her studies is that it's somewhere between 40 and 50% of what we do every day is just habit in the same context. And if we don't change that context, we're probably not going to assume that habit's going to change that much. So I came up with this little infographic. Hopefully it comes out well, because I was just like a last minute throw in there. And I realized that for a lot of us, it's kind of like the old iceberg analogy, right? It's a very popular thing out there, right? There are habits we're aware of, and there's a lot of habits that we're not. And when we're in survival mode, the unconscious habits tend to be the ones that typically be the most prominent because we just want to get through the day. And so if part of my habit is I have to get up and I've got to walk 4 miles with a backpack weighing somewhere between 80 and 100 pounds, And I can't stop until I find somewhere else to rest my stuff safely and securely. How is it ever going to help me get to a point where I can actually say, I'm feeling a bit better? Or what, as Sandy likes to say, what would that even look like? So in our clinic, when people come in, and that was a very rough segue, by the way, but when someone comes in to the clinic for service, one of the things they all get is an automatic screening for depression. And it's through the PHQ-9. If you're not familiar with it, there are a lot of really good articles that have it in a variety of situations and what the indications are for what the scoring means. But typically, when someone scores in our clinic, if they're usually at about a 10, they'll get an automatic referral to our behavioral health counselors. And we have an amazing team that I work with to kind of integrate what they're doing and what I'm doing. We also use this. It's called the Prepare tool. And again, this may not be something you all are familiar with, but it is, when I show you how we've modified it, even though it's not technically validated what we've done, we get a much better sense of how we can actually get to some better information. And I think this graphic is really cool. So we just address basic needs. Do you have transportation issues? Work? Do you have insurance? Are you in food stress? Housing stress? And then that gives us a little bit more to work on. We have a lot of resources we can access. But again, if the provider's not going to be having the time or the intention to ask these questions, then what happens to that person when they leave that doctor visit? They go home or wherever they're going to the exact same situation that is making their life much more harder to manage. So when they come in to see me or they see a provider, that had to do this for Ben, because if he was thinking it, he is now, that if there's an issue on a high score for our behavioral health folks, it might be suicide ideation, there may be self-harm, and they get immediately, our medical assistant will go contact the behavioral health and say, this person needs you right now. I do the same thing. And I've also had people come to me who are needing a little bit more advice before they go home about back pain, knee pain, shoulder pain. So in the time that I have left, which is rapidly declining because this clock is not stopping, I was reading a book for being a better parent for my son. And this was the book that our psychologist recommended. It's called The Power of Showing Up by Daniel Siegel. And if there are people here from last year, some of these themes will seem really, really familiar to the presentation that Maxie Michuk gave to us all and her pictograph of the box, which I still think is one of the coolest things I've seen relating to building a therapeutic alliance ever. I didn't put descriptors here because this is for you to figure out. How do I, as a clinician, make my patient feel safe? Knowing now there's some things that are out there that I can't control. But I can't control the environment in the clinic. So one of the things I do to make them feel safe is I don't sit by the door. I create a spot where if they feel like they need to get up and leave, I'm not going to get in their way. But I also create a space where they don't have to feel like I'm interrogating them. I took a page from Peter O'Sullivan, and I sit lower than they are. And if they try and get lower, I get lower. As much as possible. I don't wear this, by the way. That would be kind of edgy. But I want to make sure they're seen as well. That's that validation word, right? They need to know that I'm there for them. And in the course of my interview, or when we're just talking, I do ask about their story. Some give me a very confused look because they've never been asked that question before, and they may not be ready to tell it. Some are like, oh, where do you want to start? I'm kind of like, wherever you feel is necessary. And they'll say, when I was 7, I fell out of a tree. And I'll be like, okay, I'm with you so far. But there's a lot that builds from that moment when they realize that I'm not there to tell them what to do.
All right, thank you very much, Jamie.
The pleasure is all yours.
It really wasn't. But, okay, well, let's do the questions, and then you can do the twirls. Okay, so the first question's from Alice Sanvito. Any thoughts on why the homeless population is so disproportionately male?
Again, I'll give you my opinion, because most of the patients that I see are men. And what I find is there's a lot of mental health issues that I find, and as well as addiction issues, whether it's alcohol, that's the main one that I see. That tends to be also the men that for the, I hate using the word breadwinners, but there's a lot of shame in our culture in, quote, a man not being able to hold their own with employment. And so very oftentimes, they're the ones that then get depression, they start drinking or getting further into their opioids, and then they're the ones that end up just walking out. They don't seek out help. They don't want to ask the questions. The women that I've worked with have been a lot more open about seeking services. They ask more questions of their doctors, but they also get completely ignored by a lot of other healthcare providers because they're being, what's the word, hysterical? What a horrible word. I'm not sure that answers the question directly, but this, from what I've seen so far, seems to be the pattern.
Okay, now a question from Robert Haddow. Thank you. This is a fantastic talk. How do you manage to maintain consistency and quality of care when you're regularly dealing with such heavy material? I personally don't know how I'd stay consistent without burning out.
This is my joke gag, just so you know. But honestly, and okay, I gotta do my horrible Ben Cormack imitation. If I'm being honest, it's hard, and I honestly don't know that I'm doing it well. I have a lot of issues that I've bounced with people who are very close to me. I've sought out advice from my mentors, Sarah and Sandy and some others, because this is something that I grapple with every day. But at the same time, I feel so driven at this point in my life to do something a little bit more impactful because I'm also attempting to be a role model for my kid. And so I think I don't do the best job of managing stress, and kind of dovetailing on Mark and Sandy's talk last year, I've moved from the high levels of burnout to a mid-level to where I think I'm beginning to feel like there's some positive movement towards me not completely falling down on this. Because I am the only physical therapist for our entire system of 18 clinics, and I'm building something that I have no idea where it's going to go, what it's going to look like in a year, let alone what it's going to look like in 6 months. So it's tough. I hear the shittiest stories that you could ever imagine wanting to hear. And I'm not going to say I'm sitting there stoic. I wish I could say, oh, well, that's interesting. I cry. I hug my patients. And sometimes that's all we do. Sorry.
All right, next from Rachel, my whistleblower. We've heard about the importance of validating the person pain experience. Is there a difference in how we validate a person's homelessness without sounding condescending?
Yes, because I can tell you I've done both. And I learn really, really quick when the person thinks I'm being condescending. It's not like they're sitting there silently. They pretty much say, I don't think you heard a word of goddamn what I'm saying. That's not at all what my problem is. I've had that throwback at me. And not having a sounding board, not having people to kind of collaborate with all the time, I'm still kind of wandering in the weeds. And this is really how I've been learning communication through trial and error. I have had patients get up and walk out of a session because my demeanor was not something that made them feel safe and secure. I'm okay admitting that I have sucked on days because in order for me to suck a little less, I have to acknowledge what I did that was not meaningful to that person. And so, yeah, there have been some tough nights where I laid awake thinking, how could I have asked those questions differently? What could have I done differently so that the next time that happens, I'm a little bit less of an asshole?
All right, next from Haley Spillane. Hi, I work in a FQHC as a PA in Central Valley.
Where am I? Where can I do the air high fives? Somewhere across the room?
Over there.
Oh, thank you. Double, double, double.
But she works with farm workers who can't afford to take time off of work due to do the PT. Do you have any resources I could look into for some basic exercises that I could start with my low-income patients who aren't able to see a PT?
Yes, I do. Right now I'm working with our health coaches that do some basic training with and education with some of our patients coming in to figure out how to move a little bit differently. And that's what I spend a lot of time doing, by the way. My approach to strategies was from Tim Beams in his class last year, where he put a pen on the floor and said, go ahead and pick that up 10 different ways. And each way has to be different. So if we think about habits, how often do we think about our go-to habits for picking something up off the ground even, or how we do a work function? So once I have them do that, and I challenge them to say, let's come up with 2 or 3 different ways of doing that feel good to you, or feel safe to you. And so it doesn't take a lot, and if they feel like they have a few more options, then sometimes they feel more confident going back to that work environment to begin to get through the day with a little bit less of that stress and that pain that's going to maybe make their day at home or the next day just as much as misery that they had that first day. That kind of rambled at the end, so hopefully that made sense.
Oh, that was great. Okay, we have one from Michelle Bellamour.
Okay.
I wonder, let me get it up there. I wonder if you can speak to how trauma is addressed with the homeless population you work with. In the context of Bessel von Koch's belly, I don't know. The body keeps the score, trauma related to chronic pain.
So I don't know if this is fitting that model, because I honestly don't remember names as well as I used to, as far as even articles I've read. I mean, Ben rattles them off. I mean, it's pretty amazing to see that guy. I don't remember the newspaper articles that I read, except for Nick's. But our director of behavioral health, when I first came on board at my orientation meeting, talked a lot about trauma-informed care, about how all that influences the person. And we heard a great introduction to that yesterday with Dr. Noel and her introduction to the adverse childhood events and how much of that kind of past trauma shapes how we respond to things later in life. And so getting a better understanding of that, being okay with hearing the stories and beginning to figure out what is really maybe going on that we can actually address, because as Sarah likes to remind me, there's shit we can change and there's shit we can't. So we have to first start with what we think is going to be most meaningful based on our understanding of the evidence, and then put that into a framework that will fit our patient's belief system and be a viable option for them. I have no idea if that answers your question, but I've got my email and stuff, so if we want to talk further on that one, I'd be more than happy to.
Awesome. All right. And that was the last question. So well done.
Wow. Thank you guys so much. Whew.
Okay. So
Anyone
now
have a fan?
I know it does get toasted. All right. So it is lunchtime now. So if you guys could please make sure you exit out these doors over here, and do take a moment to check out the vendors who kind of help make this all happen.
There we go.
That was a better twirl. But yeah, so if you could just take a stroll by, see what they're up to, and then we're going to be back at 1:50 if you want to win any of the wonderful prizes. And then we'll be starting up with Jared Hall at 2:05.